It is our February Georgia Memory Insight, GM Insights. And our speaker today is one who's familiar to all of us, Dr. Ted Johnson. He's going to talk with us around preventive care in dementia, which is not routine as it turns out. So without further ado, I will hand it over to Dr. Johnson and feel free to put your questions in chat. I'm glad to monitor that. And we will go through those toward the end. And then we'll, of course, talk about our CME and other logistics at that point. Dr. Johnson, stage is yours.
Hey, thanks so much. It's great to see everybody and excited to cover this topic. I learned a lot by covering this topic and benefited from reaching out to a lot of friends and colleagues. And so I'm going to drop some names to talk about contributions that folks made. So this is part of our CME series, and we do offer credit for this, and you'll find out more about that at the end of the presentation. And also, this is, sorry, it's bouncing around a little bit. Let me try this forward button instead. There we go.
I'm not seeing your slides.
Oh, so sorry.
They were up a minute ago and then just came down.
Okay, I see it on.
I can see the slide.
I see it on my end.
Oh, then it's me. Okay, great.
Okay.
Proceed.
So no disclosures for this. And here's some learning objectives. So we're going to walk through some tools such as the e-prognosis tool that can be used to predict function and survival, which is an important part of what preventive services you want to do and which ones you might pass on. We're going to use tools from there and others to predict a median survival relevant to persons living with dementia. And we're going to use the concept of time lag to benefit to frame whether a specific patient will experience only upfront risks with little chance of living to see the benefit, and understand how the annual wellness visit can be used to develop and communicate a personalized prevention plan. All right, so this is a real live patient that is seen in the Integrated Memory Care Clinic. Shout out to Allison Schlanger, who's a nurse practitioner extraordinaire that is seeing this patient. I'm working with Nurse Liz Beatty to do an annual wellness visit. And so here are the three components of the annual wellness visit. There's a health risk assessment, there's a provider consultation, and then one of the mandatory required elements of exiting an annual wellness visit is to deliver a personalized prevention plan. So I wanted to talk about the health risk assessment actually being a good source of inputs for you to do the rest of the work, and that you need to personalize this. And part of the personalization will be life expectancy and time lag to benefit. So here are important topics for another lecture on prevention related to dementia that I'm not going to cover today. But there's some really great work done by the Lancet. And if you go and look at Lancet figure prevention dementia, they update this all the time and show some really important ways in which people without memory impairment can have a healthier life and lifestyle, and look at some modifiable and non-modifiable risk factors. And also there's some very interesting stuff that's related to prostate cancer and breast cancer about anti-hormonal therapies and how they might be related to the pathogenesis of Alzheimer's disease. And so again, we'll pick up on some of these topics later, but not what we'll talk about today. But let's start with the patient, because I think that this is a really important topic, and I think it flows better with a real patient. So this is a 74-year-old patient seen in the Integrated Memory Care Program who was signed up for an annual wellness visit, a subsequent annual wellness visit. The diagnosis is mixed Alzheimer's disease, vascular dementia. It's late onset, it's middle stage. There are behavioral changes that are actually quite involved. And so stroke, hypertension, elevated lipids, prostate cancer treatment, and we'll finish with the prostate cancer. There's no diabetes, no pulmonary problems. This is a person who lives at home with a wife who is a caregiver, drinks 3 drinks a week, no tobacco, BMI is 25, and there's some ADL dependence and also IADL difficulty, and those are inputs that we'll see later. And this is a person who's mostly sedentary and watching television at home. All right, so we're going to talk about what information from that is going to be useful for us to figure out some of these questions. So we'll start here. I actually go to this site a lot. And so if you put in a gender and a birth date, the Social Security Administration will give you a predicted additional years of survival and an estimated total years. You Google Social Security survivor calculator, and it just gives you some information that's specific to US beneficiaries and gives you some ideas. All right, so let's just give an anchor for a ballpark just based upon gender and age. And so for somebody who's 74 in 1 month, and this is not his actual birthday, I just put in a year to give us some general idea. 12.6 years of additional life expectancy. So let's use that as a starting point. Obviously, this is somebody with dementia that is late onset and moderate stage, and it is mixed. And so a very interesting article from Sweden actually took a look at their whole health system and looked at people with dementia, got some information, not so much about stage, but about mini mental state exam. And they offered some predictions. And so let's call this gentleman 75 rather than 74. We'll go into the box that's vascular dementia and mixed, which is the box that we're at. And then that gives us a 3-year survival probability. Not the same as a median life expectancy, but that gives us some ideas about, all right, are we in the right ballpark? And so 3-year survival probability for someone in that range is somewhere between 60% that they'd live 3 years and 70% that they live 3 years. And so this is for a sample of folks who are diagnosed by a memory clinic and are living in the community. So our initial Social Security estimate of Social Security estimate of 12.6 years, that's probably not the right number. So let's get even more specific and put in some information that we got from the annual wellness visit to figure out, all right, so what's a real median life expectancy? What are some ranges? So ePrognosis is a really useful site from the University of California, San Francisco. If you go into ePrognosis, there are multiple calculators, but I pulled down a calculator that's specific, that's been recently published in the Journal of the American Medical Association in not too long ago. I think it was 2023. And this gives you survival estimates from a pool of people who actually have ADRD. They're not staged, and there's not a specific diagnosis. So it's a little heterogeneous. But if you put this piece of information in, again, age goes on in almost everything, and gender goes in almost everything. You've got BMI. Is there difficulty walking several blocks? Yes. Does the person do vigorous activities? No. How many ADL dependents are there? 1 out of 5. How many IADL difficulties? And I think it was financing and financing and transportation. And maybe there was one other that was related to meal prep. It's not fair to take away points on a ADL difficulty if you've never ever done the task. And so that's just a caveat there. Negative for tobacco, negative for DM. Sorry, this is a positive for cardiovascular disease based upon the stroke and based upon some of the other things going on. So that is positive, and no COPD. So if you put those in, and you actually get this output, 5.3 additional years of life. The 2.7 to 8.5 years is an interquartile range, meaning that the 25th percentile of survival versus the 75th percentile of survival. This was done on a sample of 4,200 people. They're validated dementia, as I said, but there's not a subtype. This was derived in one sample and validated in another sample, and it's believed to be good discrimination. So I think that this gives you some useful information to give you kind of are we talking about 2 years, 5 years, 7 years, 10 years, 12 years? And that'll come up in a second why that's important. If you went to the primary care symposium at Lake Lanier, you saw Lee Jennings, our awesome colleague from Oklahoma, get to this same point that we're about to go to by talking about function. And so it's interesting in terms of looking at the output, and I'll go back, the inputs, and I'll go back to that just a second ago. There's not a whole lot about dementia stage and dementia specific diagnosis, but there is information there about function. And if you play around with the function buttons in a given case, you can change the estimated median survival by about half a year by increasing the number of instrumental activities of daily living, or by a little bit more by giving more ADL dependence. And so that information is really ends up being important. Okay, so what next? So one of the things that happens in an annual wellness is that you're given a lot of care gaps to, can you click on this and solve these care gaps? And so there's some vaccine care gaps. There's screening for abdominal aortic aneurysms that's recommended for this patient by EPIC. And there's also a satisfied care gap for colonoscopy. And there's a colonoscopy that was done for this patient 2 years ago. This is a care fragmentation, because this was done outside of our health system and we don't have perfect access to where this was done and what the actual pathology will report. But based upon the family report, and this care fragmentation is really problematic in people with memory loss. But basically the recommendation was, let's look at repeating this. So let's go into a little bit more information about the life expectancy, which we're going to pin at 5.2 years. And we'll look at the time lag for benefit, and we'll go back to the Hippocrates tool. Time lag until benefit was a topic that our program director of our preventive medicine residency and fellowship, Sarah Turbo, encouraged me to just spend a little bit of time on, because you either know exactly what this means or you have a little trouble figuring out what this means. And so ePrognosis, again, has 12-minute videos that have been condensed into 30-second videos, and 2 of them to talk about time lag to benefit. And I recommend these to you just as a quick review. I did both of these, and to save you the 30 seconds for each of these, I distilled them into another slide. And so here's the time lag to benefit spiel in one slide. So if you do preventive service X, to recommend and to reduce the future chance of preventable condition Y by 8%. But doing so may take X number of years to see the decreased chance of preventable condition. And doing the preventable service X may cause adverse effects. Now, I left some of these numbers in red because it's a little bit harder to find these data than I actually thought it would be. And they might be in numbers needed to treat, numbers needed to harm, but it's actually a little complicated to find all these. But I put some examples in here about time until you see reduction. And that's what we're going to put against our median estimate of life. So some of these have immediate benefit and very few harms. Thumbs up to those. Some have delayed benefits, maybe some mild harms. So all the way down to colonoscopy, that's probably something that the patient's unlikely to live long enough to benefit from the procedure, which is language that's used in those 2 videos. So here's the major piece of information from the time to benefit analysis that you get. You take your life expectancy, and this is a little sliding tool, and you move it across the top. You anchor at 5.2 years. Red are things that would probably not be recommended for the patient. Green are probably things that are useful for the patient. And then that sort of gives you some ballpark estimate of what to do. Sarah DuPont, who does an awesome job of helping us with all our annual wellness visits and pushing us towards giving robust personalized prevention plans, says to go in and inactivate the AAA screening for abdominal aortic aneurysm so that it doesn't keep coming up on care gaps and has somebody in the patient's care deciding that, oh, this is recommended, we should close that care gap, because we should not. If you look at some of these other things that are up and down the screen here, you can see that there's things that are not relevant to his care, but if they were important, finasteride for BPH, bisphosphonates for osteoporosis are in a green area based upon life expectancy. Blood pressure and statins are as well. There's probably compelling information for someone with mixed Alzheimer's disease and vascular dementia to make sure that you're treating the blood pressure and the statins. And you'd probably have to flip that life expectancy to much shorter than it is. So let's go one slide more, and then we're done. So this is kind of what we thought about what was going on with this patient and what we should do. Continue to treat hypertension, lipids, prioritize a pneumococcal vaccination, stop colonoscopy, and deactivate the abdominal aortic aneurysm screening. Way back in an earlier slide, I told you something about this person's prostate cancer. And so I called the former chair of the Emory Urology Department, Marty Sanda, who's an expert in prostate cancer. And I walked him through this scenario and I wanted to see what he had to say. But before I show you what Marty said, I'm going to just pause and stop sharing screen. And I'm going to ask you to weigh in the chat as to what you would do with regards to further monitoring for prostate cancer with annual PSAs in this gentleman. Again, this is not screening for prostate cancer. This is someone who already has a diagnosis, had a surgical attempt at cure, who had positive margins at the surgery, and it was in 2019. So I'm going to look for folks voting in the chat as to would they do PSA surveillance? Yes or no? One
Yeah.
recommendation for no. Yep. Go ahead, Carolyn. I'll let you.
Okay. We have several more that would not do it. One would likely stop, depending on the what the patient would want in terms of treatment. Prefer not to, but still do STM. Vast majority say no. A few caveats in here.
I thought this was a fascinating conversation with the former chair of urology. All right, so here's the details again. So the patient had a PSA of 12 prior to biopsy and prior to surgery. The Gleason score was 7. The pathology was 3B. There was adenocarcinoma at the left lateral mid-margin, urinary bladder neck, and surveillance was done yearly, and all of the PSAs were less than 0.1, showing that there's no recurrence. And so the now what question is interesting. So if you look at the 10-year estimated recurrence of prostate cancer, it's 50%. If you look at the chance of having some sort of symptomatic recurrence with pain, bony involvement, and the like, that's about 10 to 15%. So now you're playing some odds here about, all right, so what are the competing risks that they have? I think that what's compelling for me is if you unlink checking the PSA to a reflex action that we must treat this because it's elevated. And if we figure out the rate of rise may actually tell you something, and then the interventions are more measured and targeted. You have better tests today than bone scans and CT scans with a PSMA PET scan, if available. And so I think that one of the things that sometimes gets us into trouble is this kind of ongoing, let the train roll down the tracks where there's no controls over the speed that this goes down the tracks. And so I do feel that there's some thought about shared decision making, about doing further monitoring and doing shared decision making about if we get this value, then what happens next, which I think is really, really important in these patients. So I am going to go to the last slide, which tells you how to get information to ask for attendance and to get credit. And I'm going to leave this up for just a second, and then I'm going to stop sharing. And I welcome conversation because I think that this is a useful way to think about it. Is it practical? I'd love input from you and thoughts about it. And I'd love questions about this patient in particular and information or questions that you have. So thanks so much.
Hey, Ted, thanks for that talk. A question that I frequently confront is continued use of statin in individuals as they get older. I guess my gut feeling is as their life expectancy declines, the importance of statin use would also decline. But uh, do any of the calculators sort of indicate when we should maybe peel back on a statin?
So I think this is a really important question, and I know that Chad Hales is on, and so I'm gonna ask him to come on after I give this topic a swing. I think that with a patient with mixed Alzheimer's disease and vascular dementia with some pretty robust um, strokes, that I would try and do everything that I could to manage cardiovascular risk, including blood pressure control. And I think that part of this is also a question about what are you trying to prevent? Are you trying to prevent major adverse cardiovascular events, or are you actually trying to help with progression of disease and actually slow that? Hey, Dr. Hales, do you think you can come off mute and offer some thoughts?
Sure, I'm chewing. Um, yeah, I would agree with that. Um, Patients ask me all the time whether they should come off of it because of some of the reported contributions to or potential impacts on memory and cognition. And I usually have that discussion of, well, if it's going to keep you from having a heart attack or stroke, you do have to kind of weigh, well, if it's not really causing too much of an issue with other side effects such as myopathy or having other adverse effects, then certainly reasonable to continue. But as you reach a certain stage in your cognitive impairment, it also becomes difficult to give or take medications. And so you do have to weigh that in with your decision making, as well as at what point does it become a quality of life issue with trying to force medications. So I'd say it kind of varies per patient, but I err on the side of saying, hey, you should probably treat as long as you can.
I'm going to circle back to Emma and just actually that's Dr. K masquerading as Emma in just a second. Carolyn, I'll give you a chance. Thanks, Chad. I'll give you a chance to swing at this question as well. When do you think about stopping blood pressure and lipid?
Yeah, so I think that question of treatment versus prevention is a really relevant one. And I think that I thought the e-prognosis scale actually has something around lipids that sits around 3 years. I was also just looking at not everyone has access to this as readily as something like e-prognosis, but the geriatric review syllabus is what's brought this to my attention, this topic recently. That's from the American Geriatric Society, and they make geriatric review syllabus and a geriatric nursing review syllabus, very similar documents. And they're even in the screening list for moderate or middle stage dementia, which this patient
I didn't get to it. And
has, their recommendation is to consider screening. So the other question about maintaining the medication is if we're using it for the purpose of vascular dementia progression, then I think the other question is, do you check lipids? That's not really the target. We're not treating to a target lipid at that point. We're treating for a different reason. So that was my other sort of addition to it.
All right. Thank you. Very helpful. Thanks.
And Dr. K, you had a question.
Yeah, I'm not sure what's going on with my sign-in thing,
That's
but
okay.
I agree with the Chad on statin use. But if patients have had a history of any kind of cardiovascular disease, I think the evidence is more favorable for continuing the statin and not stopping it, because the chances of them dying from heart disease is still the number one killer, right? My question is about the e-prognosis tool as to how you use in a clinical setting, because you know it's it has its issues too. It does not incorporate any social determinants of health or severity of condition. And here you are telling a patient, look, I think you might you might die in like 5 years. So I feel like that's this is this might not be a good idea to do. I just don't know how you show it to a patient, the result of an e-prognosis.
Hey, thanks for that great question. We have a tool that looks at your gait speed and gives you an estimated mortality based upon your gait speed alone. And I think that in our work with that app and whole program, people were very uncomfortable with this. And so one of the ways that, by analogy, one of the ways that we did with this gait speed and survival thing is that we flipped it on its head and said, here's the things that you should do if you have a slow walking speed. You should go to physical therapy. You should do mobility and strength training. And so maybe on this side, this is a conversation about things you need to worry about and things you don't need to worry about. I know that there's been an article that I thought was very useful by Alexia Tork, who was an Emory resident who went on to great fame at University of Indiana. And in her qualitative work with caregivers of persons living with dementia, they actually were happy to not have to do some of these things anymore. And so I do think that you can frame this in a, here's what you have to do more of, here's what you have to do less of. I know that Allison Schlanger came on, and it's so great to work with Allison, and she's taking care of this patient. And Allison, what would your thought be about, would this family be interested in doing less? You're on mute.
Knowing that they're already making some changes with respect to lifestyle and making some important decisions about travel and curtailing some travel because of how it affects him, I think they definitely fall into the camp that less is more. At the same time, they are a couple that are terrified of the word cancer.
I do think that we wind up with patients that we go, why are we sending this patient to mammography? And there's some element of, I can't control my neurodegenerative process, but I can control not getting breast cancer. And so I do think that that's what the shared decision-making point is about. It's like, what's important to you? And so Allison's really pointing that out, that, maybe a colonoscopy, not so much, but, maybe monitoring PSAs to figure out if there's something that we can do and be thoughtful about what we do. Maybe that's in the cards. I see Dr. Asoma Jula coming in about, from a practical treatment standpoint, when do you use e-prognosis and how do you apply it in your patients, and do you discuss it? I think that the e-prognosis site has gotten more patient and care partner friendly than it used to be. There's more interesting materials there. I do think that how to normalize, making a mortality estimate. Maybe you take a page from finances, and the fact that the first calculator that I showed was Social Security Administration. The Social Security Administration's interest in giving you a mortality calculator is to allow you to figure out whether or not you want to take your benefit at age 62 or your benefit at age 67. And all of that depends on what gives you more money. It all depends on what your life expectancy is. And so maybe there's some thought about, going back to those videos and listen to how they talk about, you might have side effects from the preventive treatment that we're offering you, but you might not live long enough to have the benefit. A lot of people die with prostate cancer, but not everybody's killed by prostate cancer, sort of example. Hey, thanks for that. Fishing around for Birju Patel, LifeSpace is another interesting prognosticator. I do find that LifeSpace is a very interesting tool. Hope that you have a chance to look that up and find that. And then e-prognosis talks about statins in primary prevention, not secondary prevention. Agree that they're sort of framing it in terms of primary prevention, and there might, in terms of progression of disease process, there's probably a different outcome that you get. Hey, Dr. Cohen, great to hear you and see you.
How are you? Great presentation. Just to go back to that idea, I think it's useful, the e-prognosis, for us to have an idea of how we kind of personalize and do patient-centered care during the visit, and try to focus on what is really important for us and what really matters most to the patients and the families. So that kind of helped me a lot to kind of go through and center the discussion of what I think we should focus based on the prognosis. I don't necessarily disclose the data, say, hey, your chances of being alive in 5 years is %. I don't kind of like to use it that way, but I think it's very, very useful. And it's also useful when I'm teaching residents, because this tool was really adapted from a group of geriatric patients. So the first question is, does the patient have dementia? Yes, no. And then the functional assessment. And it kind of helping you realize that the prognosis is really based on your diagnosis or not of dementia and on the functional assessment much more than in any other diseases that you have. And that's why I think it's relevant. But I don't show the numbers, but it really helps me to center in what I think we should talk today, and always thinking about what matters most and incorporate that into the into the care of patients living with dementia. Thank you.
Thank you. I think that's it for us today. I'm going to stay on for a little bit longer just to hang out with my friends. And so always good to see everybody. And thanks again for joining us today.
Thanks, Dr. Johnson.